well, I would like to welcome Emma. Emma is an assistant professor in the Faculty of Education and a member of the Brain and Mind Institute at Western. And her lab is the Developing Brain Laboratory, which is a great name, and is a nominee for a Tier 2 Canada Research Chair in Neuroscience and Learning Disorders. Dr. Deurden trained in psychology and neuroscience at McGill and the University of Montreal, and then trained in autism during a postdoc fellowship at the Hospital for Sick Kids. Her research is focused both typically at developing and clinical populations and focuses on brain behavior relationships in children and adolescents with autism, as well as infants who are born very preterm and thus are at higher risk for autism and ADHD, and that's what we will hear about today. So welcome to CPRI.
Great, thank you so much. And thank you so much to Rob and Sarah for inviting me to present. So as Rob noted, I'm a new faculty member here at Western, and I started my lab back in July. And I have a number of new investigations that are ongoing, but today I'd like to talk about some longitudinal studies that I've been participating in with infants who are born very preterm. And this is research that has been conducted in collaboration with researchers at the University of British Columbia and also at the Hospital for Sick Children where I trained previously. And for these studies, we used brain imaging methods, mainly magnetic resonance imaging, and combined it with neurodevelopmental assessments. And what I want to focus on today is the importance of studying early adversity, so factors such as pain and stress and brain injury, and how it can impact early brain development, and how we can use this information to inform us on functional outcomes in this high-risk population. So preterm birth is associated with birth at less than, under 37 weeks gestation. But for my talk today, I'm going to be focusing on infants who are born very preterm, born less than 32 weeks of gestation, or those born extremely preterm, less than 28 weeks of gestation. So preterm birth is very common. It's in 1 to 2% of all births, and the hallmark feature of preterm birth is a very wide variation in terms of the developmental trajectories, in that many of these children will go on to develop common childhood neurodevelopmental disorders. So, for example, preterm birth is associated with a high risk for the development of autism. Autism is prevalent in about 1.5% of the general child population, so 1 in 66 Canadian children. But in the preterm population, it's 10 to 20%. And similarly, for preterm birth is also associated with increased risk of ADHD. ADHD is prevalent in 5% of the general child population, or 1 in 20 children. But in the preterm population, it's 40 to 60% that will go on to develop, to receive a diagnosis of ADHD. So both autism and ADHD, these are disorders associated with early onset and variable developmental trajectories. And a key question that remains, though, for very preterm born infants is how can we predict outcome in this population? How can we examine the factors that are promoting risk for later cognitive, motor, and sensory impairments. And the approach that my colleagues at UBC and at the Hospital for Sick Children have taken is to examine early adversity, so factors like early pain and stress, brain injury, and to use brain imaging methods to identify the brain regions that may be most vulnerable to early adversity, and then to use this information in order to predict later functional outcomes in this population. So the brain is undergoing an exponential period during development, represented here by these MRI scans. So the first one is of an infant at 25 weeks, and again, scanned again at 40 weeks gestation, so around the term equivalent age, the time they're intended to be born. And you can also appreciate the exponential growth between infancy and childhood. And what I'll be focusing on today during my talk is the impact of early adversity, particularly stress and pain and clinical care factors. And using brain imaging, we demonstrated that these factors were associated with the arrested or delayed development of key gray and white matter brain structures, and was associated with adverse motor, cognitive, and sensory outcomes. At the same time, though, in the preterm population, we do see that many infants who've had a very difficult clinical course, and yet they can, when they're returning to clinic later on, we can see that they are outperforming their term-born peers. So a major question is why? What is explaining this large variance in terms of the developmental trajectories? And so for my talk today, I'm going to be focusing on these key factors, early adversity in neonates, and how linking this information to alterations in brain development and to later motor, cognitive, and sensory outcomes, focusing on a series of studies in groups of neonates who were born preterm. So this is an average neonate here being treated in the neonatal intensive care unit. And you can see that the baby is intubated, they're getting help breathing. And all of the baby's heart is being monitored, the baby's wearing a blood pressure cuff. So many parts of the baby are being monitored, but what isn't being monitored regularly is the baby's brain. And when we do MRI, we can see for those of you who may not be so familiar with looking at MRI, this is taken an axial image going through the brain, and it's taken at around the level of the eyes. So these are the eyes here. And you can see how smooth the cortex is. And when we follow the babies with MRI till 42 weeks, the time they're intended to be born, you can see this exponential growth that is occurring just during these few short weeks. And by term equivalent age, many of the features that we see in the adult brain begin to come online. We start seeing the curvature of the gyri and sulci. And we can use brain imaging to tell us about brain structure, function, and metabolism in the neonatal brain, just as we use brain imaging to study the adult brain. We can use brain imaging to tell us about brain structure. We can use it to differentiate the gray matter in the cortex here from the underlying white matter. And we can also use it to tell us about the subcortical brain regions, so for the thalamus here and basal ganglia. We can also use it to tell us about brain injury. So these bright white spots, which are the blue arrows we're pointing to, this is known as punctate white matter injury. You can think of this as being mini strokes impacting the white matter, impacting the white matter fiber pathways, connecting the subcortical areas to the cortical areas. We can also use brain imaging to tell us about white matter microstructure using a technique known as diffusion tensor imaging, or abbreviated as DTI. And this can tell us about the integrity of white matter microstructure. And the different colors here are reflective of the different orientation of the white matter fibers. We can use functional MRI to tell us about brain function. And this is an indirect measure of neuronal activity and measures blood flow changes in the brain. And what we can see here in orange is the statistical map overlaid on a structural MRI showing activation in the visual cortex in a neonate. And lastly, we can also use MRI to tell us about brain metabolism. So here below, we can see these are the different metabolites that we can measure using magnetic resonance spectroscopic imaging, including NAA or N-acetyl aspartate, and this is a marker of neuronal integrity. So we can use these different brain imaging techniques to tell us about different tissue types, such as gray matter, white matter, and we can also use it to tell us about brain function and metabolism. So for the studies that I'll be presenting today, the neonates, they were scanned within the first few weeks of life with MRI using those different MRI sequences that I referred to in the previous slide to study brain function, structure, and metabolism. The infants were scanned twice, and this allows us to study the growth of the brain during this short time period and understand how early adversity can impact that growth. We then asked families to return for neurodevelopmental follow-up at 18 and 36 months, where they're assessed with the Bayley scales of infant development. This is a standardized test where you can assess motor, cognitive, and language function. But for the most part at these ages, we focus mainly on motor and cognitive outcome. And lastly, the families returned at pre-K kindergarten age at around 4 to 5 years and were assessed on the short sensory profile to assess sensory functioning. So neonates being treated in the neonatal intensive care unit, they're likely to suffer from the indirect effects of stress associated with care in the neonatal intensive care unit. But they're also likely to suffer from the direct effects of brain injury. So many of these neonates, 30%, will exhibit signs of damage to the white matter, demonstrated in those punctate white matter lesions that I presented in the previous slide. And for neonates born at slightly younger gestational ages, at less than 30 weeks of gestation, 15% will go on to develop cerebral palsy, and 50% of very preterm born neonates will have mild to severe motor impairments. And when parents return to clinic, they often note that the most important thing for them in terms of their child's developmental outcome is their child's motor ability, because they want to see their children outside playing. And as researchers, we often focus on cognitive ability as being a major predictor of outcome, as it predicts academic ability, and we know it's associated with quality of life. However, for children to be playing outside and playing sports, that's a really important social aspect, working on their social development. And we know social emotional learning is also a major predictor of cognitive development. So in turn, motor, cognitive, sensory functioning, they're very much intertwined with one another, and I'll come back to that later on in my talk. So as researchers, though, we had this question of how do we take this information about damage to the white matter, and how can we associate it with later motor outcome in these neonates? So the neonates in the study underwent early MRI and returned at 18 months for their motor assessments. And they were assessed on gross motor and fine motor skills. They would be assessed by a neonatologist or a psychometrist for these tasks. And the type of tasks they would be involved in would be grasping, stacking blocks, walking upstairs, and sitting. And so we had these scores on the Bailey that we then related to the injury data, the early injury data. So in order to examine brain injury in this population, we had the early MRI scans from each individual baby. And in order to quantify the injury, we had a medical student manually label every single voxel in that MRI scan with where the injury was occurring. And then we wanted to ask, can we see a pattern across the neonates? Is the injury occurring sporadically, or is it occurring in the same place? And to do that, we merged all of those 3D maps together and we overlaid them onto a common template, and that's what's shown in the next slide. And in fact, we do see that there is a common pattern of injury. So this is the map overlaid on a template MRI with the warmer colors indicating the brain regions where there was exact overlap in the neonate, showing exactly the same regions in the brain had white matter injury in that same location. And you'll note here that this is the central sulcus on either side. And so the central sulcus is the landmark for the primary and the primary motor and sensory cortices. So in the territory, the white matter underneath the sensory motor cortices, this is where we see the highest incidence of injury occurring. So we then had this information and we wanted to relate it to the motor findings when the families are returning when the infants are 18 months. So we had the white matter injury map from the previous slide and we related it to the motor outcomes. And the images here, the images with the bright voxels, these are areas in the brain that were associated with poor motor outcome. So going back to using this landmark point, the central sulcus, which is here, you'll notice that if the babies had a lesion in front of the central sulcus, in the white matter fiber pathways that are primarily underneath the primary motor cortex, the premotor cortex, the supplementary motor cortex, this was associated with adverse motor outcomes. But if it was behind the central sulcus, in the area of the parietal cortex, this would be associated with very low incidence of adverse motor outcome. So in turn, a clinician can use this information for a neonate which presents with injury in the brain, and they can say to a family whether the likelihood of a neonate having motor injury, having motor impairment later on in life. So we wanted to go just one more step further And we wanted to examine how does injury impact brain function and structure in the brain. So we had another group of neonates completely separate from the other group that we scanned with MRI twice using the same protocol. We mapped the brain injury just as we had before, and that's shown in these blue and purple maps here. And again, we find the very similar pattern of brain injury presenting in this new cohort of very preterm born neonates, where the area in purple is the region where we had the highest incidence of injury. And again, this is the central sulcus here, so occurring just in front. So we wanted to examine how does this injury impact functional networks in the brain. So those are the maps in orange and yellow here, demonstrating that the babies who had white matter injury, these babies had unilateral activation of one hemisphere or the other and showed less robust activation in comparison to neonates who had no white matter injury. And we see that in these babies, they had bilateral robust activation and comparable to what we see in term-born neonates. In turn, we wanted to examine how does white matter injury impact the functional connectivity of these brain networks. And we extracted brain activity from subcortical brain regions, the thalamus, and also the parietal cortex. That's right. That's right. And so we wanted to examine the connectivity of these structures. So we extracted the activation in the thalamus and in the parietal cortex, and we correlated them together. And shown here in the graph in the top right is the incidence of how connected these subcortical and cortical areas are. And those babies who had a low incidence of white matter injury had increased connectivity in the brain. Those with high injury load showed decreased connectivity in the brain. And we also wanted to look at the white matter fiber pathways in relation to brain injury. And we had extracted the white matter volume, and then we extracted measures related to white matter microstructure and found that the integrity of white matter microstructure was reduced in babies that had white matter injury, indicating that white matter injury has widespread effects in terms of the structural and functional connectivity of the brain. And in turn, this may be an underlying factor for the widespread cognitive, motor, and sensory deficits that we see in this population. Oh, so well, that's very difficult to tell. So it would be around, so injury, the peak is around 28 weeks of gestation, and the median age of scan is around 30 weeks, 30 to 32 weeks. Yes. Mm-hmm.
Timing relative to an acute injury, whether that maps some of your findings in terms of fluid integrity or
Yes. That's a really good point, because for the most part, people will scan with MRI babies at term equivalent age. But these were all done at around the time the injury would have occurred. So it's really the first study to have published this. They do, yeah, and they all had ultrasound as well.
And did the MRI, the non-functional regular MRI, the structure for all the show presence?
No, so for that would be yeah, the incidence of paraventricular accumulation has decreased over the past 10-15 years. Yeah, so for these babies, any baby that had a grade 4 intraventricular hemorrhage that would be indicative of PVL would have been excluded. So because of the widespread injury, but yes, but they wouldn't have been included in this.
Any PVL, they were not included.
No, because yeah, but it is it would be maybe 1 or 2 babies in this cohort. Yeah.
You would have known that. Yeah. You would have. So on early ultrasound, you excluded the grade 3s and 4s after grades 1 and 2.
Mm-hmm. Yeah.
Yeah, any disease. Afterwards, yeah.
And the other question is, if, so the x-axis is the volume of white matter.
Yes, that's right. Yeah.
Is it possible that there's less connectivity because there's less white matter to connect to?
So
Because I mean, there's
Yeah.
more damaged white matter, there's less functional white.
yeah, I mean that could be a possibility. Certainly in terms of the results that we see. It is a small cohort, as you see from the scatter plots. Mm-hmm.
And so for all of these kids, are they on
Mm-hmm.
they were
Oh no, they had white matter injury. So that's yeah.
But they didn't have the classic CDL.
No. Yeah.
There's obviously the disease of CDL.
Mm-hmm. Yeah. So it's
You were more yeah.
mm-hmm.
Yeah.
Yeah.
Right. That's why
Yeah. But it wouldn't be in this cohort. We didn't. It would be maybe one or two babies that were excluded because they had.
that's interesting. That's a little bit. Because those are kids that do the highest.
Yeah.
And more important.
Mm-hmm. In this population, only one or two babies have been diagnosed with CP. But right now, yeah, and right now for most of them, they're turning 5. So some would be between the age of 2 and 5 now. So some of them were receiving a diagnosis at around 2. Yeah.
So you could use them that the motor is more subtle than something. Oh yeah, right. So that's for sure. That you have anything, you have a lot more motor coordination.
Yeah.
So for, do you know from other studies though, how acute injury impacts functional and neural is it, what do you think? Like what the acute injury factor versus
Yeah,
activity?
there was a study by Chris Meiser published maybe within the last 5 years, in which they included babies that had more severe injury, but then they had maybe like an N of 5 that they were able to include. The main issue is that when you're doing these techniques, you have to average the data all together. So if a baby's brain is very distorted because of the damage to the ventricles, it can't be included with the other babies' data. So, yeah, so that's the main issue with that because of the difficulty of doing the registration. Okay, so just kind of summarizing in terms of how do we put this all together in terms of, I talked a little bit about early stress and I talked about injury. So how does that all come together in the preterm brain to impact these white matter fiber pathways and to start thinking about how it impacts that later outcome. And so this is a cartoon image of a left hemisphere. And this is the cortical ribbon here. This is the ventricle. This is the thalamus, globus pallidus. And these fibers here, these represent the white, it is in aqua and green. These represent the axons that are connecting the subcortical areas with the cortical areas. And the cells that are going to be wrapping around and forming the white matter, allowing efficient communication between the subcortical areas and the cortical areas. There's these precursor cells which are very sensitive to stress. And it's thought that potentially early hospital-related stress in the NICU can activate oxidative stress pathways and in turn specifically impact these cells. And we see the resulting white matter injury. So this is the overlaid white matter injury map. This is the thalamus here, ventricle. This is the territory of the basal ganglia. So in turn, the white matter injury is impacting these kind of key pathways between the subcortical regions and the cortex. And this may underlie the spectrum of developmental disorders that we see later on. So in turn, for the rest of my talk, I would like to focus on the impact of early adversity on subcortical development, focusing on the thalamus and the hippocampus. And so particularly focusing on cognitive and motor outcomes. So very preterm born babies, so showing the image again of a neonate being cared for in the intensive care unit. These procedures, including endotracheal tube insertion, chest tube insertion, these are procedures that are very invasive and they can be very stressful. And in turn, a neonate cared for in the NICU can experience on average 14 painful procedures a day. And the average neonate is going to be spending weeks to months in the neonatal intensive care unit and can be exposed to literally hundreds of painful procedures. And up until 10, 15 years ago, many of these procedures were performed in the absence of any type of analgesic medications. And there's two main reasons for that. The first reason is that they're thought to maybe do more harm than good because morphine, these different types of analgesics and sedatives, they're only tested in adults. They're not tested in babies, and they're used today off-label in neonates. And the other belief at the time was that neonates, they were thought to perhaps not to have a functioning pain system, and that they actually had lower pain sensitivity than adults. But in actuality, research with animals and later with humans discovered that they certainly do indeed have functioning pain and stress systems. And in fact, the opposite is true, where they actually are more sensitive to pain. So in turn, when studying early stress in neonates, a major focus was on the stress system. And this is the body's main stress system here in this graph, demonstrating the hypothalamic pituitary adrenal axis. And this system involves the release of stress hormones, so mainly the hormone cortisol, represented here in the thyroccorticosteroid, which is in animals. And the hippocampus is a key structure, as it has many receptors for cortisol. And studies in animals and humans have demonstrated that increased stress is associated with increased cortisol release and can impact the hippocampus, and can be associated with neuronal degeneration, and also it can impact cognitive functioning. As we know, the hippocampus is a key structure for learning and memory. So in turn, it's thought that the increased stress response in preterm born neonates may also help to explain some of the internalizing behaviors, such as depression seen in preterm born children, as well as the difficulties with sensory processing and working memory deficits, which are quite prevalent in this population as well. So in turn, we were very interested to study the hippocampus in preterm born neonates. And this is, of course, a very challenging task because the brain of a preterm born neonate is about the size of a clementine orange. So the hippocampus is a teeny tiny structure inside that orange. And this is showing, on these images, this is showing our manual segmentation protocol. And you can see it's really only a couple of voxels. These would be 1 by 1 by 1 millimeter voxels. This is very time consuming and labor intensive and involved two large teams coming together to extract the hippocampus in this group of neonates. But it allowed us to extract the data, and which I'll show you on the next slide. On the y-axis is the average hippocampal volumes in cubic millimeters, and on the x-axis is the age at scan. And so remember that the babies had 2 scans. They were scanned early on within the first few weeks of life, and again at term equivalent age. And what we can see in looking at the data in orange, which are the early scans relative to the late scans in green, that the hippocampus demonstrates significant linear growth during this period and grows about 40 cubic millimeters a week, so quite a bit. We then wanted to examine the relationship between the hippocampal growth, which is on the y-axis, in relation to the total number of skin-breaking procedures, which is shown on the x-axis here. So they had a maximum of about 350 skin-breaking procedures. And we found that there was a significant negative association between the growth of the hippocampus and the total number of skin-breaking procedures. We then wanted to examine how does the hippocampus grow in relation to cognitive assessments. So we, yeah.
You know who did start this? Okay,
do I know?
At the very bottom, whose hippocampus didn't grow at all. You know what their problem was? Okay. But it's concerning.
Yes. Yeah.
But the hippocampus didn't grow at all. Whereas presumably their brain continued to grow.
Well, that's the other question too. Where did they start out? Where did you already do the grow? Yeah. Right?
Yeah.
Right?
Yeah. Mm-hmm. Yes.
And you wouldn't necessarily know that. As kids who have difficult in utero.
Yes, but that's a big initiative. That's a huge initiative right now to scan. Because there's many babies we know who's going to be born early, so babies with intrauterine growth restrictions, so it's going to be medically indicated when they're going to be born. So that there's a big push to see them before they're born. Mm-hmm.
But what would that do, though?
Well, the magnetization helps brain development. I think we all know that.
Well, part of that.
Yeah, but yes, but the reason to scan them would be to say, because they don't know, for a baby that's IUGR, they don't know when they should be delivered, right, in terms of outcomes. It's an estimation. So they would want to see if there could be brain-based biomarkers, which are risk factors for poor outcomes, and to see if a baby stays in longer. So in congenital heart disease, now the baby is kept till 37 weeks, and then they'll do the surgery that week. So, but they want to keep the baby inside as long as possible. And the same for IUGR, it's a real trade-off because of the failing placenta. And in terms, yes,
right? They often
very stressed.
They often do quite well if they're born independent because they were
Can put on weight.
stressed.
Yeah, they can put on weight after in the extrauterine environment. Mm-hmm. Yeah.
But the head says this IUGR did very well because they've already been pre-stressed. And the other ones doing it quickly and really do quite well, as opposed to the other appropriate birth rate for age group affected.
Mm-hmm. Yes, it's a fascinating population. So for these babies, we had them come back at 18 months and were assessed on the Bailey, motor tasks, as I discussed previously, and cognitive tasks as well. For the cognitive tasks, they are assessed on attention, memory, visual preference, sensory motor manipulation, and concept formation. And so we had this information, and so the Bailey is a standardized test. The mean is 100 and the standard deviation is 15. So when looking at the hippocampal growth in relation to cognitive outcomes at 18 months, we see in the babies who are performing well on the Bailey, they're performing within one standard deviation of the mean. We see nice linear growth of the hippocampus. However, for babies who perform poorly on the Bailey, who are performing more than 2 standard deviations below the mean, who may have significant cognitive impairments, these babies exhibited slower hippocampal growth. And this was specific for the cognitive outcome, not for the motor outcome. There's no association between the growth of the hippocampus and motor outcome, indicating that the growth of the neonatal hippocampus could be an important predictor of later cognitive ability.
What's the correlation between the Bailey and later IQ scores?
Oh, I don't know.
Like, does it actually predict later IQ? Yeah, I've often wondered, what is an IQ at the age of 1? I mean, I know it's a measurement, but does it actually correlate reasonably well with the risk score later on, or not?
We can answer those questions with this cohort. Mm-hmm.
Yeah.
Yes, the data are signed. They continue to be followed, these babies. So we can answer that. So maybe when I give a talk next year, schedule me for December 2019. I'll come back with that answer, Rob.
And there's often debate about what happens, right? A lot of these kids have a lot of community, right? From health perspective. And so as those become better, and they also have this thing that goes together, not to improve in that peaceful.
Yeah, so you need big numbers. Yeah, correlated very well.
Difference, but and what are the difference of base colors?
Yes. Mm-hmm. Yeah. Well, because of the cortisol exposure. So we did have cortisol measurements in these babies, but which wasn't, So we do have the cortisol data, but we never included it. And it was cortisol data are very difficult to analyze. And so we do have all of those data in those babies, but that would be the specific for the hippocampus, the stress sensitive brain area.
Hippocampus, though, not specific. I think every psychiatric illness has an abnormality in the hippocampus associated.
Yeah.
But in this way, you've got measures of cortisol to explain or to correlate. But in terms of the overall hippocampus, everything. It's probably very sensitive to any insult.
Yeah. Mm-hmm.
And that's
Yes.
why technology
Not yet. We're working with it.
Okay, so that was for cognitive outcomes. So we wanted to look more specifically at the other subcortical structures, which could be impacting motor and cognitive outcomes. So what could be explaining some of the variance in the motor outcome data. So in turn, we switched our attention to focus more on the thalamus. So the thalamus is a key region in the brain. This is the main sensory reeling nucleus. And I noted that this population is exposed to a number of invasive and stressful procedures, and in turn, it's directly impacting the somatosensory system during those invasive procedures. And so, and due to the widespread alterations and the widespread variations in developmental outcome, this could indicate that thalamocortical pathways may be centrally involved and explain a lot of the variance in the data that we have for these neonates. So for pain pathways, they become functional at around 24 to 28 weeks of gestation. But yet the ability to modulate this pain endogenously, this is only coming online much later. And so for many of these babies who are born extremely preterm, they may be at most risk for the vulnerable effects of stress and pain. And so we specifically focused on these babies. Additionally, previous work by our colleagues with very preterm born neonates, they had examined metabolic development of the thalamus in very preterm born neonates. And shown here in this graph is N-acetyl-aspartate, that marker of neuronal integrity on the y-axis. And on the x-axis is the postmenstrual age at scan in weeks. And the data in red are the babies who had a higher number of skin-breaking procedures, indicating that babies who are exposed to a greater number of painful procedures may be at risk for slower brain metabolic development. And in turn, they also found there was an association with gestational age at birth. So we wish to examine in extremely preterm born neonates the association with later thalamic development, which is shown on this graph. So the neonates were scanned twice, and in the graph on the y-axis is thalamic growth in millimeters cubed, and on the x-axis is the incidence of pain, whether they were exposed to high or low pain, and when that was occurring during their stay in the neonatal intensive care unit. And those extremely preterm born babies who are exposed to high numbers of skin-breaking procedures, particularly during the first month of life, had slower thalamic growth. Then we examined the thalamocortical projection pathway, so in terms of how the thalamus is projecting to the cortex using diffusion tensor imaging, so that measure of white matter microstructure. And again, in extremely preterm born babies, their white matter microstructural integrity was significantly impacted, demonstrated slower white matter microstructural growth. And in turn, we examined these findings in relation to the motor and cognitive assessment. So this is now at 3 years of age. They've returned at 3 years and were assessed on the daily using the same fine and gross motor tasks, as well as looking at cognitive ability. And we found that the growth of the thalamus was associated with both motor and cognitive outcome in this population. So this was, though, at 36 months. So, and we found that there was regionally specific alterations in the thalamus, and in turn, this may be that the early stressful, painful procedures are impacting the thalamic macrostructural growth, and in turn, those white matter fiber pathways, which are connecting the subcortical areas to the cortical areas. And particularly, it demonstrates that extremely preterm born neonates may be at most risk. However, a key question though that remains is what is occurring later on in kindergarten? Do these measures, is it related to later in life outcomes? So we wanted to ask, how is this related to the development of specifically of the thalamus to the neonates when they're returning as children? And they were assessed on the short sensory profile, which is not a standardized test. You may not be familiar with it. The typical performance range is between 155 and 190, and it's assessing very broadly sensory functioning. So tactile functioning, visual functioning, auditory functioning, olfaction, gustation, movement, and sensation seeking. And this is based on parental report in the neonates. So we examined the scores on the short sensory profile in relation to the total number of skin breaking procedures that the babies had received. And so where the blue line is, this is typical performance on the short sensory profile. And we see that the neonates who've been exposed to a higher number of skin breaking procedures during the neonatal period had lower scores on this short sensory profile, indicating sensory deficits. We then examined it in relation to the growth of the thalamus. So on the short sensory profile scores are on the y-axis, and the growth of the thalamus is on the x-axis. And we see that the babies who have better scores on the short sensory profile above the blue line, which is indicative of typical performance, have increased, they're showing linear growth of the thalamus in the neonatal period. We then wanted to ask, what about the babies who are exposed to a high number of skin breaking procedures? What are their short sensory profile scores looking like in relation to the total number of skin breaking procedures? And we see that the babies who have slowest thalamic growth and the lowest scores on the short sensory profile were also those babies that were exposed to the highest amount of pain during their care in the neonatal period, indicating that the skin-breaking procedures early on can have long-lasting effects on the development of the thalamus and the somatosensory system and impact later sensory processing. We also wanted to examine the findings on the short sensory profile scores in relation to the white matter microstructure, again looking at the thalamocortical pathways connecting the thalamus to the cortex. And we see that for the babies who've been exposed to a higher number of skin-breaking procedures, the data on the right, they in turn had the babies who had decreased white matter microstructural integrity had the lowest scores on the short sensory profile. So in turn, in these babies, extremely preterm born neonates, they may be most vulnerable to the early invasive stressful procedures. And this can be impacting the thalamus and thalamocortical pathways and may be an important predictor of later sensory processing. Of course, this was based on a parental report, and it was including all types of sensory processing. So in turn, it would be of interest to, and as the children are returning now, to look at subtypes of sensory perception and to do quantitative sensory testing in the children themselves and relate it to the growth of the thalamus in the neonatal period. However, this may be an important biomarker for understanding how neonatal pain can be associated with later sensory processing deficits and can be used as a biomarker for childhood sensory impairments. And so, kind of in summary, this research examining early adversity in relation to brain development and functional outcomes can have implications for later early interventions and therapies that may be impacting particularly the regulation of brain networks involved in salience perception, reward, memory, social cognition, attention, executive functioning, in order to promote adaptation to stress and resilience in this high-risk group of neonates. And I'll just stop there. I thank you very much for your interest, and I'd be happy to take questions at this time.
Question.
That's a great question. So non-pharmacological pain was, for some of the babies, was a part of care. So the parents were just encouraged to do it, but it wasn't documented. So in our newer cohorts, it was documented when the parents were there, how long. Yes. Yes, it's going to depend on the style of the NICU. So some NICUs it'll be 60 beds in a room like this, and it will be residents and doctors and nurses constantly coming in and out. So some families don't feel comfortable to be there all the time. Some are the NICU here. This is it's half-half. There's some semi-private rooms. It'll be 2 to a room, or it'll be 4 to a room, depending on the illness severity of the baby. But and then at Mount Sinai Hospital in Toronto, they had private rooms. So for the babies and the families, they get a private room with a bench, and they can put up a screen. And they can have private time, so they feel more conducive. So kangaroo care, you have to put the baby on a bare chest, so people will feel more comfortable to do it in that type of environment. But it just depends on the NICU level. So sick kids is level 4 NICU. The babies are there to get a surgery that can only be conducted there because of the specialties, and they'll be staying for a couple of weeks, and then they'll go to a level 2 NICU or to a level 3. So in that case, though, the nurses need to see all the babies to see if there can be a baby, having a code or something like that. So it just depends on the style of the NICU, and in turn how the parents feel about being there. Yeah. Yes. Yes.
It was not long ago that right?
Yeah. Yep. Mhm.
From a long way.
Mhm. Yep.
Can you go backwards just like?
Yes.
Well, there's 2. No, you put the character down, but now it's be part of the
Yeah. Mhm.
part of
Yes.
Any idea what because I think we focus a lot on what causes problems, but we don't really focus on resilience and what.
That's right.
So people had sort of a lot of skin breaks, but had a good their fractional endoscopy was higher, or they had the higher.
Yes. Who are those babies?
Any idea what's different about them? Obviously they have higher scores in the short sensory profile, which is one difference. But any idea why?
No.
What you kind of hypothesize?
Well, I mean, it can be it can be so many factors, right? They could have therapies, socioeconomic status plays a major role in this. So we have a member of our group last year, they found that post-secondary education in the mothers was a major predictor of outcome, more so than brain injury in the neonatal period. So that could be a factor. It could be factors completely unrelated to the neonatal course, and it could actually be.
If the mothers had more education, you can surmise they may have a higher level of intelligence.
Mm-hmm.
So they may have a better brain to begin with.
They could have, yep. Mm-hmm. Yep. So that could be a factor as well. Yeah, that's kind of really unknown. Yes. Mm-hmm.
Because this cortisol in the mother, does that get transferred to the victim?
Yes, it does.
But the mother is really stressed also.
Yeah. Mm-hmm. Yeah. Mm-hmm. Yes, yeah, we have a couple of new cohorts that are ongoing now. Mm-hmm. So we're still enrolling, that are being enrolled now. Oh, well, yeah, well, so in vitro fertilization can play a part in that because it's associated with multiple births, so twins and triplets. So we do see spontaneous triplets in ICU. That certainly does happen. Yeah, so multiple births, and also, so some families, they've done IVH, and they've done it 10 times, more than 10 times. It's over $100,000 they've invested, and they would like to have a child, and if a child has deficits, they see it as something that they'll be able to handle later on. So babies are being born earlier, as early as 22 weeks, oftentimes because they'll counsel the parents, but the parents wish to continue, and they wish to continue with they will go to, they'll use the life-saving measures for the neonates, when before they wouldn't, resuscitate after 23 weeks. Just because of how difficult the course can be for a neonate. So that can definitely play a factor, and they're much better at keeping babies alive. So that's another, so we do see deaths in the NICU, we do, but yeah, there's survival and morbidity. So yeah, so survival has increased, but morbidity has remained the same. Mm-hmm.
The question is that there is so many compounds, especially even when you're looking at those early
Oh yes.
factors. So the thalamus grows. How do you control for severe illness? Like we're saying it correlates to skin prick, and obviously
yes.
that also means. So how do you control for things like oxygenation,
yes.
all the things that are as well?
Yes, if this was a talk at rounds, at grand neurology rounds, or from a neonatologist, I would have presented all those horribly boring tables. And so we adjust for all of that in the analysis. So days of mechanical ventilation, any exposure to morphine, midazolam, fentanyl, all of that information, information about brain injury, all of that is taken. So from the minute the baby is born, the cord gases, everything is all documented, and measures of maternal and obstetric health. So we have all of those data. And so certainly we don't look at everything, but we know that there is key risk factors. So days of mechanical ventilation is the #1 predictor of brain development. So, and many of these babies are ventilated. So we have our kind of select ones that we include, but then we'll look in the data. So for example, we were looking at, in some of the studies, was extremely preterm versus very preterm. So we would look at the demographic and clinical variables to see that were significantly different, and then we include that in the model. But the models are very large in the end, but not too large. Yes, there's a balance. Yeah.
Short subject profile. So if they score below a certain level, it's considered problematic.
Yes.
Does that mean overreactivity or under, or it can mean both?
It could mean both.
So if people have their thalamus is enclosed, but I'm just thinking sort of
yes.
later on, if you think about people with autism and
yes.
People with short autism, people with autism typically have over hypersensitivity,
yes.
or they have hyper as opposed to hypo, although both are reported.
They can be both, yeah.
But if people have overstimulation early and their thalamus is growing early, you think that would be with a reduced responsivity to things.
Yes, and actually some very preterm born children, they actually, it's like an autism.
Yeah.
They have a very wide spectrum in terms of some are hypo and hypersensitive to pain, for example. And so this would indicate that extremely preterm born babies may be the ones who are kind of at most risk. And so the older you are, the less susceptible you would be to these harmful effects. So it may be that in the autism population, it could be something like that, where there's a specific window where they were overexposed to invasive procedures, and that could result in the impact on the thalamus and sensory outcomes.
And so then, if I'm correct, then you predict that people with autism who are not really sure, but then people will be more likely to be hyposensitive later on. Well, I guess
it could be either, yeah, but depending on the time that they are born. Yes.
Yeah, the one's very good.
Yeah. So yeah, I mean, it would be great to answer some of those questions about preterm birth and autism, but so if it's only 10 to 20% of preterms that go on for later ASD diagnosis, then, you have to test thousands of babies to be able to get. So for these studies have the, 200, 250. So then we only have, 10 babies in the end for the diagnosis. Yes. Yeah.
see, I mean, then you have to be sick.
Yes.
Two of them,
Yeah.
and you can see which way it goes.
Mm-hmm. These are all questions. These are all great questions.
The functional knowledge thing that you have not yet. If you ask people at the Institute of Psychiatry, you might disagree, but that's because they have high sensitivity and specificity, but low positive response. Yeah.
Mm-hmm.
For that. And what is it? But somebody reading an academic journal is not the difference.
But very.
Great. Thank you.
Emma, thank you for coming.
Yeah,
and
thank you so much.
for ending our year. So January 9th.